Mastering access of lower extremity veins is becoming an increasingly important means of diagnosis and treatment of lower limb venous conditions. This presentation will detail access of the posterior tibial vein. We will discuss the identification and access of the posterior tibial vein using ultrasound, as well as advancement of wires and catheters into the lower extremity veins. We begin with prepping the foot and ankle, as seen in this picture. This is typically a two-person procedure and often requires both people to wear sterile gloves to maintain sterility. Once the foot has been prepped, a standard cath drape is placed over the area and a hole is cut to allow exposure of the foot and ankle. Sterile towels are then placed over both ends of the cut drape to maintain sterility. Understanding the anatomy of the venous system of the lower extremity is necessary prior to beginning an interventional procedure, since most clinically important diagnoses and treatments revolve around the deep venous system. Knowing which veins drain into the deep versus superficial system is critical. Since the posterior tibial vein drains into the deep system, we will focus on gaining access into the posterior tibial vein. Ultrasound is the most reliable means for proper vessel identification. The medial malleolus is the landmark used. The ultrasound probe is positioned posterior to the malleolus. Real-time ultrasound visualization allows for identification of the vein and artery, which lie parallel to one another. Color Doppler imaging is key to identifying arterial and venous flow. The vein is also more easily compressed, thereby giving an additional identifying feature to confirm that the proper vessel has been selected. A 21-gauge micropuncture or radial access needle can then be inserted under ultrasound visualization and then confirmed with the appearance of non-pulsatile blood. A 0.018-inch wire can then be introduced into the vessel and directed under fluoroscopy or ultrasound until it is in a position to place a sheath. We typically use a short, hydrophilic sheath from 4 to 6 French for diagnostic purposes and 6 French for therapeutic procedures, which are advanced over the 0.018-inch wire. A simple hand injection of contrast under cine angiography can then be used to define the lower extremity venous anatomy, serving as a roadmap for the advancement of wires and catheters. This slide demonstrates the advancement of a Berenstein catheter, which was used for contrast injections to define anatomy further up the leg. We can see here that the popliteal vein is full of thrombus, which helps in defining the treatment zone we wish to target with our therapy. The thrombus burden in this patient extends to the level of the common femoral vein, identifying the proximal extent to which therapy will be applied. Here we continue to advance the Berenstein catheter up the superficial femoral vein to the level of the common femoral vein. This will then allow us to place our wire past the thrombus and exchange for our EKOS catheter. The final positioning of our 50 cm treatment zone EKOS catheter is completed to deliver therapy.